All right, I think we are live. So can you all please let me know in the chat box if my audio and video is clear? I'm just waiting for the comments. All right. Okay, right. So I think we'll start. So first of all, I hope you all attended the quiz and you found it beneficial. And this is basically the discussion part of the Monday midday quiz. So just a set of 10 questions from the topic of rheumatoid arthritis. And as I said, I hope you all attended the. There is an echo from technical team. Can you please mute your side? I'm hearing echo. And this is basically the discussion part of the Monday midday quiz. So just a set of 10 questions from the topic of rheumatoid arthritis. And as I said, I hope you all attended the. There is an echo from technical team. Can you please mute your side? I'm hearing echo. And basically, the hello. Can you please mute your side? Can you please mute? 10 questions from the topic of rheumatoid arthritis. And as I said, I hope you all attended the. There is an echo from technical team. Can you please mute your side? I'm hearing echo. And basically, hello. Can you please mute your side? Can you please mute? Okay. And as I said, am I audible? Technically, can you please mute your side? I'm hearing it. Hello. Hello. Can you please mute your side? Can you please mute? Okay. Yes, so I think, sorry for the technical delay. Now, can you please let me know in the chat box if my audio and video is good so that we can start the session without any delay? Please let me know in the chat box if my audio and video is good. Please give me a thumbs up. Muthukumar, Aishan, Amal. Yeah, all right. I think we'll start. So once again, welcome to all of you for the short and crisp discussion of the 10 MCQs that were asked in the Monday midday quiz. So this is basically a series of quizzes that we are conducting in the DocTutorials app every Monday at 9 p.m., which is followed by a discussion at 9:30 p.m. Discussion will be just for around 20 minutes. And at the outset, let me just tell you that this is going to be only a very short discussion. This is not going to be an elaborative test and discussion type of session. So this is going to be a very crisp discussion. Okay. So first of all, let me know in the comment section whether you liked the questions or not. Yes. And as I see in the ranker section, see, I can see that somebody has answered in 12 seconds. Well, I know that, this is some sort of malpractice. So such entries will be removed. See, what usually happens, I can understand. You write an exam first from your friend's device and then, you write from your device. But you should also understand that I have also gone through these stages, okay, of MBBS, MD, as well as DM. So I've written quite a lot of exams. And for rheumatology, well, I was the national winner of the Indian Rheumatology Association quiz during MD days. So I feel I'm quite good at it, and I cannot do it in 12 seconds. And I do not expect you also to do it in 12 seconds. So only the genuine winner will be awarded the prize, because we can see from our backend who has answered what questions in what seconds. So 12 seconds is humanly impossible. So obviously it is a malpractice by using the first device at 9 a.m., 9 p.m. and then, you check the answers and then give the exam. So it's quite understandable that will be disqualified, and only the genuine winner, I think this will be Dr. Rubina Khatun, who has answered in, I think, just over 1 minute. She'll be awarded the prize. Okay, so I think that's fair enough. Yes. Yeah. So I think let's go for the discussion part as well. Okay, so let's go to the questions one by one. Okay, so first question, false statement regarding the serology of rheumatoid arthritis. Remember, for NEET PG and INI-CT, rheumatoid arthritis serology is very important, and often you get questions revolving around the rheumatoid factor as well as the anti-CCP antibodies. They're asking you the false statement. Okay, so I'll be crossing off all the true statements. The first option says rheumatoid factor may be positive in normal individuals. Well, this is actually a true statement, because 1 to 5% of the normal population, okay, less than 5%. Harrison says 1 to 5% of the normal population may have a positive rheumatoid factor. So because of which that is a true statement, and I'm just crossing off that option. Okay. The second one, diagnostic specificity of the anti-CCP antibodies is 95%. So when you compare rheumatoid arthritis factor, RA factor, and the anti-CCP antibodies, the anti-CCP antibodies are more specific for rheumatoid arthritis. So sensitivity-wise, the rheumatoid factor has a sensitivity of around 75% or 70 to 75%. And the sensitivity of anti-CCP also is in that range. Some books say 65, some books say 70. Just let's take 70%. Whereas specificity-wise, it is the anti-CCP antibodies which are very much specific. And the second option is also true. It is 95%. So I'm striking off that as well. Okay, right. The third one is anti-CCP antibodies have got prognostic significance. Remember that rheumatoid arthritis factor and anti-CCP antibodies, both of them have got prognostic significance. But when you compare both these antibodies, the anti-CCP antibodies have got more prognostic significance, which means if you have got a very high titer of anti-CCP antibodies, it indicates poorer prognosis or more severe disease. So I'm striking this as well. The last one, positive IgG rheumatoid factor is seen in 75% of patients. So rheumatoid factor, it can be seen in a good number of patients with rheumatoid arthritis. And if you look at the various isotype of antibody seen, you can have either the IgM antibody, IgG antibody, you can have IgA antibody, but overall it is the IgM antibody or the IgM isotype that is present in majority of the patients. So this option D is actually factually wrong. It is not the IgG rheumatoid factor. It should have been the IgM rheumatoid factor, because of which that will be the answer here. Answer will be option D. Okay, answer will be option D. Any doubts regarding this? Please ask me in the comment section. Okay. Okay, right. So I think we'll go to the second question. Second question is regarding the pulmonary involvement in rheumatoid arthritis. The question is asking you false statement regarding pulmonary involvement in rheumatoid arthritis. Option A, CT scan shows honeycomb changes in the periphery and lower portions of lung, which is actually correct, because when it comes to pulmonary involvement in rheumatoid arthritis, one of the pulmonary manifestations is interstitial lung disease. Now, this interstitial lung disease can be mainly of two patterns. One is the usual interstitial pneumonia pattern, and the next one is non-specific interstitial pneumonia pattern. These are the two common radiological patterns. Which is more common in rheumatoid arthritis? It is usually the usual interstitial pneumonia. In case of UIP, the CT thorax will show honeycomb changes, especially in the periphery and the lower portions of the lung. So this is a true statement, and I'm striking off that option because they are asking about the false statement. The next is restrictive pattern of pulmonary function test. Yes, since it most likely causes an interstitial lung disease, pulmonary function test will show a restrictive pattern, because of which I am striking that as well. The third option is Kaplan syndrome is characterized by pulmonary nodules. So we know that patients with rheumatoid arthritis, they are having higher chances of developing pneumoconiosis, especially on silica exposure. And this rheumatoid pneumoconiosis is referred to as what, children? Kaplan syndrome. Okay, and this Kaplan syndrome is characterized by pulmonary nodules. It is a true statement. And what about the last option? It says transudative pleural effusion. Well, this is actually false. In fact, in case of rheumatoid arthritis causing an effusion, one point you've got to remember is that it is usually an exudative effusion. Exudative effusion and not a transudative effusion. Also, please remember some additional points that rheumatoid arthritis associated pleural effusion, they usually have got low sugar values in the pleural fluid, and also you may get cholesterol crystals as well. Cholesterol crystals also may be seen in the pleural fluid. So answer is option D. So can you please let me know, Dr. Nitish, Dr. Vishal, Dr. Atira, Dr. Shahib, are you all clear? If yes, please give me a thumbs up in the comment section if you're clear with the explanations. As I said, I'm just going for very concise, crisp explanation and not going for a detailed test and discussion type of video, right? Okay. Now, next is which pair of disease-modifying anti-rheumatoid drugs are safest to be used in pregnancy? So we know that in case of rheumatoid arthritis, the drug of choice is usually methotrexate. But when it comes to pregnancy, please remember that two important drugs, number one, methotrexate, and also number two, leflunomide, they are actually contraindicated in pregnancy because of their teratogenic effect. So I'm striking off the options which contain methotrexate. I am also striking off option that contains leflunomide. Now, the pair that I've got as option A, hydroxychloroquine and sulfasalazine, yes, both of them are safe to be used in pregnancy, and that is going to be my answer. Okay, I hope that is clear. So, Amal, Hanina, Atira, can you just confirm by a thumbs up so that I can move on to the next question? I hope there is no confusion regarding this question as well. So next question is regarding the first radiographic finding in rheumatoid arthritis. Is it Martel sign? Is it subchondral erosions, periarticular osteopenia, or symmetric joint space loss? So at least a few students might have been tempted to write about subchondral erosions, because you very well know that rheumatoid arthritis is an erosive arthritis. See, you've got to also take into consideration that the question is asking about the first radiographic finding. See, what you have got to understand is that option B, option C, and option D, not both, in fact, all three are actually radiological findings in rheumatoid arthritis. But the first radiographic finding is often periarticular osteopenia. And can somebody tell me, what about option A? Martel sign is associated with what? It is associated with gout. So in case of gouty arthritis, which is also an erosive arthritis, you may have areas of erosions with overhanging edges of the bones. So erosions with overhanging edges. Erosions with overhanging edges. So this is what you call as Martel sign. So remember, erosions may be seen in rheumatoid, but the first change is periarticular osteopenia. So question number 4, it is C. Okay, I hope that is clear. Okay, right. So let us go to the next question. So I hope you're clear regarding that as well. Okay, Dr. Prajwal, Piyush, Ankush, Amna, I hope all are clear regarding this. Okay, right. Let's go to the next question. Question number 5. Monitoring using optical coherence tomography is advised during long-term treatment with which disease-modifying anti-rheumatoid drug? Is it tofacitinib? Is it certolizumab? Is it adalimumab? Or is it hydroxychloroquine? So first of all, what is tofacitinib? Tofacitinib is a drug that is a Janus kinase inhibitor, JAK inhibitor, whereas the option B and option C, they are actually TNF alpha inhibitors. TNF alpha inhibitors. Now, drugs used in treatment of rheumatoid arthritis, many of them are associated with long-term side effects. So it is very important that patients with a chronic disease like rheumatoid arthritis is closely kept under the follow-up. Now here, the question is asking about the utility of optical coherence tomography. So OCT and subsequent visual field analysis is very important during long-term treatment with hydroxychloroquine. And I can see that many of the students in comment section, Gajendra, Renuka, Farsana, Vishal, Monisha, all of them are actually correctly answering. It is hydroxychloroquine, because hydroxychloroquine can lead on to retinal toxicity. So it can cause retinal damage, and because of which you need to have periodic evaluations with optical coherence tomography. Okay, right. So that is question number 5. Option D is the answer. Okay, so can you please let me know, are you comfortable regarding that? Please give me a thumbs up if you're okay with that. Okay, right. Next is least commonly involved joint in rheumatoid arthritis. Least commonly involved joint in rheumatoid arthritis. See, I can see some students just making fun of the student who has got that first prize. Probably, they had done but just leave it, because I know you're all children, and I can imagine at your age, these are fun. So, that's okay. That's okay. Okay. But again, as I said, only the deserving student will be given the prize. Okay. So I think it's important to be fair, right? Okay. So least commonly involved joint in rheumatoid arthritis. Well, even in my lectures, I have told you that the joints that are involved in rheumatoid arthritis are usually the small joints, but again, large joints also can be involved. So both small and large, but again, more predilection towards small joints, especially the wrist joint, metacarpophalangeal joint, and proximal interphalangeal joint. These are the common joints that are involved. Distal interphalangeal joint is usually not involved in rheumatoid arthritis and is usually spared. But what happens is when patients with rheumatoid arthritis, you must understand that if at all there is a DIP involvement, it usually suggests a coexistent osteoarthritis. Okay, so presence of a DIP involvement in rheumatoid arthritis suggests the coexistence of the osteoarthritis, because osteoarthritis is such a common entity. Okay, osteoarthritis is such a common entity. And I think, a very good question somebody is asking. Swan neck is seen, so why not DIP? So remember, it's a reasonable question that you have asked, sir. We know about the swan neck deformity in rheumatoid arthritis. So can't we say that the DIP is also involved? You've got to understand that the deformities that occur in RA are not always due to bony problems. You can have associated connective tissue like tendons, ligaments, these all can be involved. Okay. So if we take into account the joint involvement per se, that is not exactly the one that causes the deformity in the swan neck type. So generally, when we talk about joints, the DIP joint per se is actually spared in case of rheumatoid arthritis, and whatever deformity that you are seeing is because of the connective tissue problem. Okay, right. So the answer here is option C. Okay. So can you please let me know, are you comfortable? Can I move to the next question? Niranjana, Kirtana, Hanina, Gajendra, Piyush Joshi. I hope all of you are comfortable. Okay, let's go to the next question. Okay. Next question is, which of the following demands is also associated with drug-induced lupus? Methotrexate, leflunomide, hydroxychloroquine, and infliximab. Okay. So drug-induced lupus, I'm sure that you all know about the famous mnemonic, that is SHIP, sulfonamides, hydralazine, isoniazid, and procainamide. Sulfonamides, hydralazine, isoniazid, and procainamide. Okay. So these are the common drugs that can produce drug-induced lupus. But do not think that this is the only group of drug that produces drug-induced lupus. You also understand that drugs like beta blockers, AC inhibitors can cause it. Okay, so even other drugs like TNF alpha inhibitors. So among the biologicals, especially the TNF alpha inhibitors can result in drug-induced lupus. Okay, so out of the options that have been given, it is option D, infliximab, which is a TNF alpha inhibitor that can be associated with drug-induced lupus. Okay, so please add to your notes, TNF alpha inhibitors, they can also cause drug-induced lupus. Okay, comfortable? Right, let's go to the next question. Okay, question number 8. Again, a very important question, not a parameter included in the current ACR EULAR. So what is this? ACR means American College of Rheumatology, and EULAR means European League Against Rheumatism. So most of the rheumatology guidelines actually come from either the ACR or the EULAR or the combined guidelines of ACR and EULAR. So one is the American guideline, the other is the European guideline. So this is a joint criteria for the diagnosis of rheumatoid arthritis. So I do not want you to know the finer details of the criteria. If you can, very well, good. But I just want you to know what are the major parameters that are included in this criteria. This is a table from Harrison. You need not learn about the individual scores, but remember that joint involvement, serology, acute phase reactance, and duration of symptoms. So based on joint involvement, you can see that scores are being put based on the joint involvement. You can see when there is more than 10 joint involvement, you are given a score of 5, but just one large joint involvement means 0.0. Serology is based on the rheumatoid factor and the anti-CCP antibodies. Acute phase reactance based on ESR and CRP, and also the duration of symptoms. But rheumatoid nodules are actually not a part of the diagnostic criteria. Okay, rheumatoid nodules are not a part of the diagnostic criteria, and that is going to be the answer. Answer is option B, rheumatoid nodules. Now, why did I specifically put this question is because many years back, there was an old criteria for rheumatoid arthritis. In that old criteria, rheumatoid nodules was a part of the diagnostic criteria. It was only later that it was removed. Okay, so the question is regarding the current criteria in which rheumatoid nodules are not a part. Okay, so I hope that is also clear. Question number 9, false regarding extra-articular manifestations of rheumatoid arthritis. So in the chapter of rheumatology, I think quite a number of times you do get questions based on extra-articular manifestations, be it of rheumatoid arthritis, ankylosing spondylitis. You do get questions. So let us see the options here. The first one is occurs in 40% of patients, which is a true statement. I'm striking off that option. Second option says subcutaneous nodules are seen in those with high disease activity. So this statement is also true. I am striking off that option as well. The third one says most frequent site of cardiac involvement is pericardium, which is also true. I am striking off that as well. Next is regarding the T cell LGL. Can somebody tell me what is T cell LGL? Can somebody tell me what is a T cell LGL? Okay, what is a T cell LDL? So LGL is large granular lymphocytic leukemia. Okay, large granular lymphocytic leukemia. Okay, large granular lymphocytic leukemia. Okay, that is LGL. Now, this is something you have got to understand here. See, in case of rheumatoid arthritis, when a patient develops neutropenia plus splenomegaly, in a patient with rheumatoid arthritis, there are two possibilities. One possibility is that he is having a syndrome. Can somebody tell me what syndrome? Can somebody tell me what syndrome? It is Felty's syndrome. Okay, Felty's syndrome is one possibility. And the other possibility is the T cell LGL. T cell LGL. Now remember that both these conditions may be associated with rheumatoid arthritis. Both Felty's syndrome as well as T cell LGL. Both of them can produce neutropenia and splenomegaly, and both of them may be associated with T cell LGL. Okay, so how do you differentiate? See, one of the pointers is, see, Felty's syndrome is usually a feature of severe or advanced rheumatoid arthritis. Okay, advanced rheumatoid arthritis. But T cell LDL can have a presentation which is usually earlier in the disease course as well. Understand? So Felty's syndrome, see, you can see here option D says T cell LGL is seen only in late stages of severe RA. See, usually it is the T cell LGL which can be seen early and sometimes late. Okay, whereas Felty is usually always late. But the question categorically says only in the late stage, which is false. In fact, one of the pointers is that T cell LGL may be associated with neutropenia and splenomegaly early in the disease course of rheumatoid arthritis, whereas the Felty syndrome is associated late in the case of rheumatoid arthritis. So that will be my answer. If my children are comfortable with that, please give me a thumbs up. Dr. Piyush Joshi, Atira, Renuka, Akshay, can you please give me a thumbs up if you're comfortable with that? Okay, answer is option B. Okay. The last question is least abundant cell type in the inflammatory infiltrate of rheumatoid arthritis. Is it granulocytes? Is it dendritic cells, B cells, or T cells? See, in case of rheumatoid arthritis, which is an immunological disorder, you've got various inflammatory cells that take part in the inflammation. So if you look at this picture, wherein one half is a pictorial representation of a normal joint, whereas one half is the representation of the rheumatoid joint. I hope you are able to appreciate the inflammatory mass that is being formed, which is highly destructive and erosive. And what do you call it? You will call it a pannus. The inflammatory mass is known as pannus. So this pannus is composed of so many inflammatory cells as well. You can see that there is lymphocyte, dendritic cells, neutrophils, plasma cells, macrophages. So a lot of inflammatory cells are there within. Now, this can cause erosion of the articular cartilage. This can cause damage to the synovium. This can cause bony erosions. So this is going to cause, most of the problems in rheumatoid arthritis. But the question is specifically on the least abundant cell type. Now, all these are there. And if you go through Harrison, they have specifically said, out of all these cells, let me see who is having or who is the most abundant cell type. Is it T cells, B cells? Remember, the most abundant cell type is T cell. T cell is the most abundant cell type in rheumatoid arthritis. But the least abundant cell type is granulocytes, okay, which includes the neutrophils. They are the least abundant. So the question is specifically asking about the least abundant cell type, and the answer is going to be granulocyte. Had the question being most abundant, the answer would have been T cells. Okay, so that is it. So I hope you are comfortable again. Yes, right. So that's it about the 10 questions that were asked in the Monday midday quiz. And the winner of this quiz will be Dr. Rubina Khatun. Okay, so congratulations. You have got all the 10 questions correct, and you have answered in just over a minute. So you will be winning the prize. But I can see that other students have also performed well. I'll just read out the names who have scored full marks. Dr. Prayog Bhagwat, who has answered in just over 2 minutes. Dr. Sayak Chakraborty, yeah, I know Dr. Sayak is also a very active member of our groups. Dr. Sachin Gurjar, Dr. Indragni Ghosh, Dr. Ritesh Kandukuri, Dr. Darshan, Dr. Atul Raj, Dr. Deepak, Dr. Aditya. So I think 9 of you, hearty congratulations. So for scoring, such good marks in this exam. So I hope all of you enjoyed the quiz, and I tried to put a mix of both medicine and pharmacology. And I did not want to put too lengthy questions because this is a short quiz, and just to reinforce your knowledge. So that's it. We'll catch up later for the next Monday midday quiz. You can also follow my Instagram page for various academic updates, dr_Rahul_Rajeev. Okay, so keep studying well, all of you. Stay happy and healthy. Please do take care of your physical and mental health as well. Okay, exams are tough. But again, I want you all to take care of yourself as well. Okay, so thank you so much for joining, and all the best. Thank you.
Can be challenging. DocTutorials presents NEET PG 2025 Live Power Pack. Whether you are at home, college, hostel, or library, our live classes will be right on your screen. Simplify complex topics into easily understandable concepts and prepare all 19 subjects effortlessly with our expert guidance. Our NEET PG 2025 Live Power Pack offers live classes for complete coverage of all 19 subjects, 19 tests and discussions, full access to NEET PG Power Pack, quick revision program, recorded sessions for reference, hard copy workbook based classes, post-session tests, and grand tests and subject tests. Our eminent faculty. NEET PG 2025 Live Power Pack, bringing classrooms to your doorstep. Enroll now.